Biobele ground. I'm a pediatrician by profession. I'm primarily a lecturer at the University of Ibadan and a consultant pediatrician at the University College Hospital.
You take care of sickle cell children, right?
Right, that's correct.
I have seen some of them. Obviously, they don't look too fine, but some of them look healthy. But the picture you get immediately you look into their eyes is that sometimes you are scared that they will die any moment.
Well, maybe with the eye of a non-clinician, they are not people that will die any moment. Many people in the public think so, but they are not so. They fall ill a bit more often than the rest of the population, but most of the time they are well. And if they keep their clinic appointments and adhere to what the health workers say to them, they will do quite well. Yes, of the truth, some of them look quite okay, and others do not look that well. This is because the severity of sickle cell disease is a wide spectrum. At one end are those who have a very severe disease and have what we call a crisis every now and then. At the other end are those who are well and look so well fed and so well nourished that you will not know that they have sickle cell disease except they tell you.
And now, in the 21st century, we still talk about sickle cell anemia. Why are we still discussing this?
Well, I think there are two main reasons. One reason I think is information. There is very little information. From time to time, the government, NGOs, make some efforts at public awareness to let people know that if you are AS and marry somebody else with AS, you may have a child with sickle cell anemia. But these efforts are not consistent. They are not consistent. If they are consistent to educate the populace, people will take better decisions, all right? So one, I said, is information. The second is one of choice. There are certain people who are informed to a certain extent, educated, but because of love, they just think they want to take a chance, and they go ahead with it. And sometimes things do not turn out the way they expect. So those are the main reasons why the commission continues to exist.
For those that decided to plunge in, is there no medical way out?
Well, for those that decide that, in spite of knowing that they are both carriers of the sickle cell traits, want to go ahead and get married to each other with the risk, well, there are ways, even though the ways are not very easy. There are ways, and the ways are expensive. One is that there is now what we call prenatal diagnosis. So in certain parts of Nigeria, like in Lagos and in Abuja, within the first 3 months of pregnancy, the pregnant mother may be able to test herself, the fetus she's carrying, to know the baby's hemoglobin phenotype, whether it's a sickle or not. All right. When that test is done by early pregnancy, and they know the baby is an SS baby, then we can know how to prepare for the baby. In parts of the world where abortion is legal, which is very, very few countries, they may then go on to terminate that baby. But in Nigeria, abortion is illegal. So even if you choose the option of prenatal diagnosis, meaning knowing diagnosis before the birth of the baby, there are ethical issues about having to abort that baby. But the other option, which I think is a bit more ethical but also more expensive, is to be able to predetermine the hemoglobin genotype of that baby. And I know that there are places in the world and also somewhere in Nigeria where the doctors will be able to pick an hemoglobin A sperm to fertilize the woman's egg, so that you don't have an S sperm fertilizing an S egg and having an S egg. You can pick an A sperm to fertilize the egg. The worst is that it will be an AS but not be an SS, and that can be done, but it's very, very expensive.
What is that procedure called?
Well, they are all part of modern genetic engineering molecular techniques. All right, it's just sex prediction, sex determination of hemoglobin genotype determination, pre-conceptual hemoglobin determination.
Coming back to the children that are already here, they are born with the SS gene. How do we help them?
Well, the very first thing is that the parents need to know that SS is not a death sentence. And in fact, the life expectancy of people with sickle cell disease in the US is higher than the expectancy even in Nigeria. Life expectancy, median survival is about 50 years, and Nigeria is about 47 years. That means if you do very well, you also live very well. So parents, when their children get diagnosed, need to come regularly to the clinic. Many parents do not know that any child with SS or SC needs to see the doctor regularly. So very often, they only see the doctor when the child is sick, and sometimes that sickness will lead on to death. But once the diagnosis of SS or SC is made, that child must be enrolled with a doctor who knows how to manage children with sickle cell disease, to see regularly and to monitor them. That's number one. And in that monitoring process, many things are done for them. Routine drugs, which they need to take, routine tests. The parents are educated on how to take care of the children at home, what to do, what not to do, what signs to look out for, and all that. And when all these are done, the children also are at risk of having certain complications of sickle cell disease.
Dr. Brown, before you proceed, what are the do's and the don'ts?
Well, some of the do's, the very basic do's are the children should drink lots of water all the time. The children should take folic acid every day. The children should take, in this environment, malaria prevention drugs. So we use paludrin every day to prevent malaria. They should also use insecticide-treated nets because malaria predisposes to them having crisis. They should also avoid cold weather because cold weather causes crisis. So whenever the weather is cold, the parents should wear them warm clothing, wear a cap, wear cardigan, and wear all that. There are also certain immunizations which are not in the Nigerian routine childhood immunization, which sickle cell patients need. So those ones are not in the government immunization, so the parents need to pay for them, but they are not expensive. All right, so we also recommend the pneumococcal vaccine and the HIV vaccine. They also take the vaccine. Nutrition is also very important. The children are often smaller in size and in height than their peers who are AA. So the parents are counseled on good nutrition to help them eat very well. In the US, the sickle cell patients are as well fed as the other population because they are educated on how. So you need to eat more to catch up, but you will still catch up and you will still do fairly well. So those are some of the do's, and come regularly to see the doctor. There are certain tests we do from time to time for all sickle cell patients to detect risks of certain complications. So when we know that the risk is there, we then put in place measures to prevent the complications. One don't, which I think parents should also know, is that they should not take drugs that contain iron. You know, very often, because sickle cell anemia is a disease that it's a condition that results in low blood levels, what we call anemia. And so, by common sense, people just think you need blood tonics to build your blood. Incidentally, in this condition, blood tonics is not what they need. Some components of blood tonic, like the folic acid and vitamins, are okay, but the iron components, the sickle cell patients don't need it because they have enough iron in their body. If they keep taking iron continuously, they will have what we call iron overload, and it will destroy certain organs in their body. So we always tell them anything that contains ferrous, any iron tablet preparation, do not take. But you can take good vitamins, you can take folic acid, you should eat well and do all of that things.
Is medication expensive?
Well, in terms of cost now, I think it's a relative thing. It depends on who is assessing. But the routine medications like the folic acid, the paludrin, they are not they are not expensive. The vaccines, the extra vaccines we recommend for sickle cell patients may appear expensive. Some range between like 5,000 naira or so to maybe 8,000 or so. But the truth is that if a child catches an infection that results from not taking that vaccine, the cost of antibiotics alone for even 3 days will be more than the cost of the vaccine. So it's still far more cost effective to take the vaccine and prevent those infections than to say, I don't have money for it.
So for a child born with sickle cell and anemia, it is not death on arrival?
No, it is not. It's not death sentence. In fact, there are professors who have had sickle cell disease. They have been a professor of even pediatrics. They have been very well established, accomplished individuals who have done very well. They are specialists in various fields of like experts, renowned people who have had sickle cell disorders and have done very well. So it's not a death sentence.
But by and large, prevention is better than cure.
Oh, absolutely. So it's not a death sentence, but because there is a likelihood of a shortened lifespan, and even if the lifespan is full, the frequent pain, the painful crisis and the distress up and down is not what somebody would want to look up to. So it's best to prevent it. So prevention is always better than cure. But if it happens to have occurred, it's not time to feel guilty. It's not time to shift blame. It's not time to break the marriage. It's not time to say, had I known. It's time to say, what can we do to make the best out of this? And people can still make the very best out of it when it has occurred.
Thank you very much, Doctor.
My pleasure.
Thank you. Now, what this will trigger is a lot of questions by the time I play it tomorrow.
Okay.
Can you create time to come on a live program?
Oh, yes, I